Okay, I think that it's time to start our third webinar. So I would like to give the welcome to all the participants. Hope you will be numerous and as the third webinar that I'm doing, the topic is about the removal of corona restoration. But before starting, again, I would like to thank you, the perfect organization done by the company OHIS, and I think that all is right settled, and so we can easily start. So for all of you that are new at let's say this group of endodontic webinar that we are organizing on advanced endodontics, I would like briefly to introduce myself. I'm Dr. Enrico Cassai. I come from Italy, the country that all of you hope you know, and has the boot shape. And I live in the north part of Italy in a little town. It's called Ferrara, and it is between Bologna and Venice. And this is my staff, so the people that every day work with me and share with me every daily work. I'm connected with the university where I teach endodontics since 10 years, and I also am active member of the Italian Society of Endodontists, certified member of the European Society of Endodontists, and associated member of the American Society of Endodontists. I also enjoy this great group of incredible skilled clinicians that is called Stile Italiano Endodontics. I don't know if you know, probably someone of you know it. And basically we have the big group in Facebook where we share endodontic experience, endodontic clinical case, and also you can share your experience, your cases, and we can just discuss about your cases. So it's a new way to have knowledge about endodontics, and we don't do only things about the Facebook group, but as we are very active about the philosophy that always connected to the idea of simplicity, feasible, teachable, and repeatable. And during this year, we developed some tools, some equipment that could really make your everyday clinical easy. So on the left side, where I'm showing with the arrow, there is probably the last tool that we develop, and it's called and it's a tool that you can use during the obturation. You can easily put the paper point, the gutta percha point, and it can easily help you on organizing in a simple and much more clean way your obturation. In the center we have Ergo. I probably didn't tell you that the name of the left obturations equipment is called Plano. In the center we have Ergo, and it's a bracelet done with silicone, where you can put your hand file, your rotary file, and you can easily take your rotary file from your handpiece, and that helps you, especially if you don't have always present the assistant with you. And in the on the right side we have the book about the retreatment that we finished the last year, so it's about 1 year that it came out in Italy. But the good news is that at the end of this year, and probably the beginning of the next year, there will be the English edition available. Back to the program of our webinar, we already talked about the treatment of curved canal, the treatment of calcified canal, and today we will treat the removal of coronal restoration. We will have in the future other two nice webinars, and I hope to see all of you and much more participants in this webinar. And again, as I told you in the second webinar, if you have any question, just type it, because someone will translate it to me in English, and if I can, I will just answer you during this webinar. Otherwise, you can just write down my email, as someone already did it. Write your question to me on the email, and as soon as I can, I will answer you, just to make it much more interactive and much more successful and much more useful for all of you. And as I told you, the first webinar will be on the next Tuesday, and we will talk about the post removal, so the removal of post, metal post, threaded post, fiber post, so all the technique and equipment that we need to successful this action. And in November we will talk about the removal and bypass of separated instrument. But back to the topics of today, so the removal of the coronal restoration. This is the summary of the subject that I would like to share with you. So we will talk about a very big issue that is very important for me, and is the disassemble. Disassemble, we will talk in a few minutes. It's a big part of the chapter about the treatment, but we can also apply the disassemble, not only talking about the treatment, also talking about the endodontic treatment. Then again, we will talk about the isolation, and especially when we have to remove some old restoration, crown, the importance of doing a multiple isolation compared in a single isolation. And then we will talk about the removal of direct or indirect restoration and the crown in the anterior and the posterior area. So let's begin talking about the disassemble. And it's not a new words, a new terms, because also the American Association of Endodontics put in his glossary of terms. So in some paper that sometimes give to all the members, a review of the literature on how important is and how efficient is the removal of the coronal restoration, the previous coronal restoration. And the intent, as it says in this chapter of disassembly, is to eliminate the coronal portal of leakage. So actually we have to remove the coronal portion of the restoration present to achieve the root canal and to do our root canal treatment or root canal retreatment if we have to face a retreatment. So basically we have to face two different situations that not even could be associated, as you can see in these two nice draw on retreatment, but anyway we have to just remove piece by piece every single obstacle that we meet during our scouting until the final working length, in order to assure to the root canal a new cleaning, a new shaping, and a final obturation, entire obturation, three-dimensional obturation of the radicular canal. And so during this lecture, as I told you before, we will talk about how to manage the direct restoration, and we will go very fast about the direct restoration on the anterior teeth because it's quite easy to manage. But we will focus our attention especially on the removal of direct restoration and indirect restoration of the posterior teeth, and I will hope that you will enjoy the tips and tricks that I will suggest in this step. And then we will move to our much more difficult subject, when we have to remove crown or veneer, especially associated with post and core, or just only post. So the first step, again, once we did it, the right diagnosis, so we need to we have to do an endodontic treatment or an endodontic retreatment to that tooth. We have to isolate it. And again, I would like to thank you, the friend of mine, Dr. Ahmed Sahat, for this nice picture. And I would like to focus my attention that in this case, well, I would like to say that in my everyday clinics, it's very difficult that I do a single isolation. I prefer to do a multiple isolation, not only as we saw in the last lecture about calcified canal, to have much more advantages on this type of isolation, but because it's better for restoration motivation. So after our endodontic treatment, we can manage better the final restoration if we have time, and I think that could give you, especially when you have to do a cavity access in not so easy way, comparing the crown to the teeth that are near the one that you have to treat, could give you a really nice hand. So it's just a question of time, so just try to improve your skill on isolate multiple teeth, and then when you become much more let's say handful, much more fast on manage this type of isolation, you will really enjoy and do it every time. So the two main factors that I would like again to underline about the multiple isolation are connected to the cavity access, as I told you before. So you can compare, especially in difficult cavity access design, the angulation of your burns, if it's right, if it's wrong, if you have just to change the actual inclination of your burn, and especially, as I would like to do in my everyday clinical practice, I just try to finish all my treatment in one session, at least from the endodontic treatment to the, let's say, final restoration, final build up, in order that the second session I just have, for example, to prepare the tooth and just to take an impression, and to have the final restoration. That could be a crown, could be an onlay, so it depends on what you have as treatment plan. And here we have the last probably type of rubber dam that you can try. It's called Vision, and it's developed by Stile Italiano. And we have also different clamp. And especially, as I told you, if you do multiple isolation, you don't need something like 50 clamps, because every time you will put the clamp in the same teeth that are probably the upper molar, from upper molar to anterior teeth, if you have to treat from canine to molar, or for example, clamp number 2 if you have to treat the anterior region, so you go from the second premolar to the second premolar of the other side. So it's also much more easier for you if you organize a multiple isolation in terms of number of clamps that you can use it, and that also helps your assistant, because sometimes they get much more confusion, especially if they have to order and manage a big number of clamps. So very fast we will talk about direct restoration on anterior teeth, because, well, especially if we have to manage an easy case as the one that I will show you, you don't have really to spend a lot of time to get lots of tips and tricks, because the much more difficult on the anterior teeth are when you have to manage, especially after trauma, after ortho, very sclerotic or calcified canals, as we told in the last webinar. So if you lose the last webinar, just take care of listen it, because I think that it's very nice, very interesting, because I think that once or twice in a month I have to face calcified canals, especially in anterior region, and anterior region are connected to aesthetic region, so we have to do our best, especially in this area of the mouth of our patient. So this was a patient with a lot of problems, a lot of decay, and you can appreciate on the right side there was an old restoration that was, yeah, for sure there was a decay, so the patient feel for sure pain, also because the decay when in contact with the pulp of the lateral incisor, so we need endodontic treatment. And we did easily the endodontic treatment, just removing the old restoration, then achieve the endodontic treatment, and at the end we again reshape the shape of the lateral incisor and the maxillary incisor, and you can appreciate that the maxillary incisor I didn't treat it endodontically, and I just tried to leave it vital, and it's about 5 years that the tooth doesn't have any sign of necrosis or acute inflammatory process. Well, the direct restoration on the posterior teeth are just a little bit more complex. So again, I would like to focus much more on these topics. And again, in these slides, I would like to underline what are the main tools, main equipment that you have to use when you have to prepare a cavity access, for example, on a posterior teeth. Well, you don't need a lot of burns, as sometimes you can hear in some endodontic course. So every endodontic course you would like to sell you a lot of endodontic kit. Just take a cylinder or conic diamond burns that has just different tip size, in order that with the same shape but different dimension you can treat from incisor, inferior lower incisor to upper molar. And you can appreciate from the picture that is surrounded by green line, where we have the same shape but different dimension. And with these three types, so we can go from a 0.10 to a 0.16 maximum, we can really achieve the first preliminary access on our cavity access design. Then you can use a multi-blade non-cutting tip burn that could help faster you on remove the big portion of the dentin of the tooth, where you are achieving to obtain the perfect design of your cavity access. And then the final part of the achieving cavity access will be done with a cavity access with ultrasonic tips, as you can see on the figure that are surrounded by red line. So when we have to remove a restoration on the posterior teeth, sometimes we have to face with amalgam restoration on a resin restoration, and our approach is just a little bit different. So let's move and see how should be our behavior when we have to remove amalgam restoration. So in this case, I will suggest you not to use a diamond burr, but to use a multi-blade cutting burn, the one that you usually, for example, use to cut metal ceramic crown or metal crown. I just show on the slide two different type of burn with the same diameter that should not be the same, but just think about of using again a multi-blade cutting burn in order to remove it much more faster and do it as you will do when you cut a crown on the high speed handpiece. And the fact that you have to use it, especially if you can new burn, that will give the much more feeling, much more fast remotion, and also you transmit less vibration on the tooth, so discomfort of the patient will reduce dramatically. And another winning point is about the reduce of vibration will lower the risk of dentin fracture or dental structure fracture, especially when the remaining dental structure is undermined by the amalgam restoration. So just use as I explained in the left side of the slide. So just start on the middle portion and just go in every direction and just leave, for example, the two boxes that are on the interproximal portion of the tooth in order to remove it with an excavator, for example. So in this case you don't touch the margin of the mesial and distal teeth. Otherwise you can insert a ledge with a matrix in order that if you touch the mesial or portion part of the tooth of the teeth that are mesial or distal of the obturation that you are trying to remove, you don't touch the mesial because you touch the matrix that is on the ledge. So on the left side we have the case with the old amalgam, and in the right side we have a control with a composite onlay that has a control, a 7-year control, and a direct restoration on the premolar. So let's have a look on a complex case like this one, and it's the typical case of, I think, the everyday office work. So when a patient comes in your office, and I'm certainly know that it happens sometimes also in your office, and the patient comes with an old restoration, amalgam restoration, sometimes also on a endodontically treated tooth. And the curious is that what the patient miss is not a portion of amalgam, but sometimes what it is broken is a portion of tooth, because as I told you before, in this very huge and big amalgam restoration, the dental structure is undermined, is underprepared, because the amalgam need a large preparation on the basement, and these under occlusion forces we don't have any adhesion from the amalgam to the dental structure, and under occlusion the dental structure has a little movement, and during the times that could lead some horizontal or vertical crack line that could lead, as it happens in this case, to the broken of a portion of dental structure. So this is the explanation that all we have to know in order to inform the patient that the risk of also maintain during the time old and very big amalgam could bring the patient to this risk. So my suggestion is to give to all your patients the advertisement that old amalgam, just take a picture and discuss and show to the patient with a picture like this one, with high magnification, and in order that the patient could really understand what you are talking about in terms of sealing, marginal sealing, and in order to also evidence if there are some crack line, for example, that are connected to the really huge amalgam. So in this case we have this problem, and the tooth was also not properly endodontic treated. So our treatment plans, when we have to change the coronal seal, basically we have also to do again the endodontic treatment, especially if we have to face with endodontic treatment that is not doing as well. So multiple isolation again, then we remove gradually all the amalgam restoration, and the mesial margin, as you can appreciate, is really undermined. So we can perform our endodontic treatment, and we don't need to do a build-up in this condition, because if we don't have, as you can appreciate here, I don't put the let's say the isolation during the endodontic treatment, because in this case I don't do, as we do in the past, a build-up. Just put some liquid rubber dam, 30-60 degree, as you can appreciate in other picture, not of this case, and you will achieve a perfect isolation. So you can go ahead, as I did it, and remove the old restoration, scout until the end all the canal, until the working length, and then obturate it. In this case I use the continuous wave of condensation, so it means system B and obtura. And then at the end I also do a restoration, so I do it with a composite only, in order to protect a very consumed damaged dentinal structure. But there was enamel, not 36 degrees, probably 270 degrees, so I just prefer in this case to do an indirect restoration in order to have adhesion with the residual portion of the tooth structure, especially if we have enamel. So if we move to amalgam, to resin, the approach that we have to maintain during the removal of resin restoration is just a little bit different. That's because if we can go in this type of situation where we have an old endodontic treatment, where the patient, as you can appreciate from the X-ray, the patient has a really problem because of an old direct composite restoration that has a really poor marginal sealing, and in this case, to obtain a better coronal restoration, we have to achieve also a new endodontic treatment, and it's not so easy endodontic treatment. We spoke about this case when we talked about curved canal in the first webinar, so if you didn't say, this part, so just take care of recover the first webinar, because it was very nice when I teach you some tips and tricks on manage curve and long canal as this one. So, but now just focus on the coronal portion. So how can we achieve a perfect access to all our orifice without damaging the pulp floor? And it's very important not to touch the pulp floor with our, for example, burrs, in order to use the pulp floor as a geographic map that lead our eyes to the position of the orifice. So if the clinician that did it, the previous treatment before us, for example, didn't find a canal, just look into the pulp floor. When we just clean it, we can see the nice sign that are present, and we can try to find the main canal if the previous dentist didn't find it, or for example accessory. So let's focus our attention on how we have to manage this part. So when we have a restoration, we just have to take care of a portion of the restoration. Let's say the 2/3 of the resin restoration with again a burrs that could be your usual burrs, should not be the same that I show in this slide, and then the other part with ultrasonic. That give you much more control, much more visibility, and you can really appreciate once you arrive to the orifice, because sometimes you have the gutta percha that is also plug on the pulp floor, but otherwise, if you have just only the gutta percha on the orifice, you cannot again take the risk of touching the pulp floor with your burns. So again, just divide your coronal restoration in the 2/3. The 2/3 coronal, use it a burr, a diamond burr, and then the apical third of your coronal restoration, remove it with ultrasonic tips. So in this case, we did this type of approach, and this is a control, a 5 years control, and you can appreciate the time that lead also my composite restoration to timing degeneration of the resin. But also you can appreciate the compare of the before of the left and the final endodontic treatment on the right, and again you can appreciate how long and how curvature, in terms of long radius curvature, we have to manage. And again, you have to understand the difficulties that you can enroll during your endodontic treatment before you are getting in. So again, spend 5 minutes looking on your preoperatory X-ray. So let's see this case where the patient came because she feel pain on this first upper molar. We have to manage a not so bad endodontic treatment, because probably you can appreciate that the dentist that did the treatment before us, well, he didn't arrive at the working leg exactly, but well, we have a radiopacity from the coronal portion quite to the apical portion. We have a nice shape, so that means that probably the clinician that did this type of endodontic treatment use rotating instrument, use gutta percha, and use gutta percha heat, condensed by heat, because you can also appreciate some holes that are present in the in the previous endodontic treatment. So these are all evaluation that you have to do looking at X-ray. And just for example, again looking at the apical portion and ask yourself, so why the previous dentist just stay a little bit far from the working length? So probably I have to manage some blocks on the apical portion at the 1-2 millimeter from the working length. So my difficulties are on create a perfect cavity access in order not to touch the pulp chamber, remove all the material on the treatment step, and then just scout the apical portion on the third apical portion in order to bypass, for example, the presence of block in this area. On the right side, we have also the occlusal view of the tooth that we have to treat. So we have again to manage a tooth with an older restoration, and well, I think that it's a quite big risk not to cover a molar with a so big and huge obturation. So just it's not necessary, it's not sufficient just to do direct restoration and take out from the occlusion the tooth. You have to protect the tooth from the occlusion. So for example, do a crown, or with so much nice enamel tissue, just do a complete coverage. And I will show you the problem that are connected to do this type of restoration on this tooth. So the patient feel pain on the chewing, feel pain on the palpation. So for sure you can appreciate just a little bit from the X-ray that there is a little radio transparency on the mesial root and also on the distal root. And I didn't put in the presentation the CBCT, where this really problem in terms of lesion it was much more clear. So the approach to achieve in the right way the coronal restoration and remove it, and to arrive directly to all the orifice without create any other problems that could lower the prognosis of the tooth that we are to retreat, is to achieve the first part of the removal with diamond burns and then use ultrasonic. So this is the multiple isolation as I showed you before, and I would like to thank you, Dr. Piotr Puchala, for the gold clamps that are really nice, especially if you use it with rubber, black rubber dam. And then I put also some fluid rubber dam in order to have a perfect sealing of my tooth, where I have to again rearrange the cavity access. So the first step is to remove the 2/3 of the coronal restoration with a diamond burn in using a high-speed handpiece, or you can also use the red one. And then we can use finally ultrasonic tips that can give you much more control, much more precision, using magnification as the microscope in this case, or just loops. After that, we remove the 2/3 of the material inside the canal without any solvent, so just remove it with whatever you want. So you can use Gates Glidden, you can use, in this case I'm using reciprocal wire in reciprocation motion file, in order again to remove the 2/3 of the material present inside the canal. And then the third portion of the material present inside the canal as obturation filling material, just remove it with solvent, K-file and paper point. So I will use this approach in all the canal. And again, we take care, especially at the beginning, of the main orifice. So I remove the gutta percha of the 2/3 of every canal. Then I will take care, for example, of the mesiobuccal. So solvent inside the canal, K-file, paper point, until I remove all the gutta percha, all the sealer present inside the canal. And once the paper point comes out from the canal completely clean, so not dirty of red, so it means gutta percha that is with the solvent is completely dissolved. I put some glide or RC prep inside the canal, and I scout with my apex locator until I reach the working length. Then once I reach the working length, I shape the canal until it's ready to be obturated, and then I move to another main canal. So for example, distal buccal. Then I do the same steps that I did for the mesiobuccal. So scout the third portion of the obturation material present with solvent, K-file, and paper point. Once the paper point come out from the canal completely clean, I use glide or RC prep to scout the third portion that we appreciate from the initial X-ray. Probably that we have to take care of a block. So just entering the block until with my apex locator, I reach the right working length, then scout it, shape it until the canal is ready to be obturated, and then move to the palatal. Once all the three main canals are ready to be obturated, I will take care to find the accessory canal. So this is what exactly I did it, so you can appreciate from this X-ray how clean is the pulp chamber, how clean is the pulp chamber in order I didn't touch with the burns the pulp chamber, and I can use the referee points of all my three orifices that actually are completely clean to try to find the accessory canal that in this case is the mesiobuccal 2 on the mesiobuccal root. So here we are. I find it. Usually I use a endodontic probe, then micro opener that we have discussed about their useful, especially also in the finding and scouting a little bit the coronal portion of calcified canal and narrow canal, and here is the same. And once you find the canal, just remove the coronal portion in order to scout it until the end. So we did it the same way, remove all the coronal portion, and then we will have a very nice straight line access, so we can just scout it with our apex locator until the end, unless it will be connected to the mesiobuccal one. So once I already shape also the accessory, just irrigate it and activated the irrigation, and then dry all the canal, and this is the picture. After all the canal, you can appreciate here the mesiobuccal 2 and the distal buccal are ready, and this is the intraoperatory X-ray where we can appreciate the palatal, the distal buccal, and the mesiobuccal on the left side. And again on the left side we can appreciate also the connection between the mesiobuccal and the mesiobuccal 2. And then I decided to obturate this tooth with three gutta percha carrier based technique, so it means thermophil on the mesiobuccal 2 and distal buccal, and I use continuous wave of condensation on the palatal. So this is our final obturation, and I would like also to focus, because at the end I just put a cotton pellet and cavite what I see it also in the first visit, but I just take a picture in this step, so you can appreciate on the right side on the picture below that there is a crack line in the buccal view that goes along the distobuccal cusp. That means that we have to think about again our treatment plan in order to prevent any future progression of this crack line that could lead also to the fracture of the vertical fracture of the tooth. So for sure we cannot think about a new simple restoration, and as I told you before, we have to think about a restoration that will cover completely the cusp of this tooth. So we can move from a crown, or we can choose a direct restoration, but unless in this case we have a lot of nice enamel, and I prefer to have adhesion so that my final restoration could really do a nice block with my prepared dental structure. I prefer in 75% when I have the chance to do a composite, or if I choose the other option, the silicate, so ceramic, complete coverage. And in this case, as you can see, on the left side the initial treatment, and on the right side the final retreatment. We also finalized the crown on the implant in second upper premolar position, and we put a nice composite complete partial coverage restoration. And you can appreciate also that with our endodontic retreatment we arrive at the apical portion where the previous dentist didn't arrive completely. Let's see another case where again we have to face with an old material, old restoration that we have to take care and not to damage in order to preserve the integrity of the pulp chamber floor. Here we have a different type of endodontic treatment that we have to take care, because you can appreciate that we have a radiopacity that is uniform, so for sure it will be the material that we have to remove from the canal. For sure it is gutta percha, but we cannot appreciate a very nice shape, and so probably we have to face with single cone, and probably the clinician that did this type of endodontic treatment don't use mechanical instrumentation but just hand. And another very nice issue that we have to take care is about the management of the pulp root, of the palatal root, because we have an overfilling of about, I think, 4 millimeters of a single cone. So if we do a mistake, just try to solve all the gutta percha inside the canal, probably you cannot remove completely the cone that is overfilled for 4 millimeters, and there is also the lesion. So we have to think about how to get the perfect reconfiguration of cavity access design, and also how to remove entirely without solving the gutta percha point from inside the canal. So the approach again is with diamond bores in the 2/3 of the coronal portion of the tooth, and then ultrasonic tip on the third apical portion until we reach the pulp chamber floor. So let's start the video. And here again I remove the all material. Then I just put some solvent in order just to get some, in order just to have some dissolution of the of the coronal portion of the gutta percha. Here you can appreciate the presence of the fourth canal, but doesn't matter because our focus now is to try to remove, especially in the palatal root, entirely the gutta percha, and then the gutta percha from the main canal, clean shape the clean canal, and then at the end take care about the accessory. So once we have solved the coronal portion, just use an H file, insert in the palatal canal, and then pull it. And in this case, I remove it entirely. So this is a successful approach, but it was connected again to a perfect study of the preparatory X-ray. So I spend 5 minutes looking on the X-ray, try to think which are the main difficulties that I can have facing this type of retreatment, and using the right approach, I really avoid to do any other mistake that could lead to a bad prognosis of my clinical retreatment. So I remove the palatal, and I remove also in the same way the mediobuccal and the distobuccal. As you can appreciate, I just go back a little bit. Okay. So here, before introducing the endoprobe, I clean and shape the mediobuccal, distobuccal, and palatal, and now I'm ready to take care about the accessory. And once the cavity access it was filled of irrigants for a long time, what you can appreciate is some bubble that comes especially from the area of the accessory canal, the fourth canal. So in this case you just put, oh sorry, just go back to the video. So in this case, just put your endodontic probe inside where you find the position of your orifice, and then again here is the micro opener, that is a K file with a very nice handling plastic handle, and then you can go up and down with the micro opener in order to enlarge the coronal portion of the canal. Here are the magnification, and you can see also the bubble. K5 10, and then that is an N2 10 or 4. I just enlarge until I reach the working length, and here is also the accessory, the working length, and you can appreciate that the two canal has a very close road, very close way inside the mediobuccal root, but they are not confluent. And here is the final obturation with 4 thermophil. So again, here we can appreciate that the two canals have a very close line way until the apex, but they are not confluent, as you can appreciate here comparing the obturation final X-ray from two different inclination in order to appreciate better the direction of all the roots. So we have talked how to take care about the direct restoration, and just get some speech about the indirect restoration that are not so far from the concept of taking care of direct restoration. Just have a very fast look if some of you has some question. Okay, no question. So again, if you have any question, just type it in the chat. I will answer you during the webinar. So this is a case, and this case was done by myself, so it was a very old only composite only. It was something like 7 years. The patient is not a very handful or expert of oral hygiene, as you can appreciate here, from the plaque present from in all the teeth. But you can also appreciate from the X-ray on the left corner that the patient can, because he feel pain on chewing, pain on the percussion, because on the build up that I did it 7 years early, I was very close to the pulp, and so during the time the pulp gets some necrosis, and when he comes you can also appreciate the presence of lesion on both the roots. So again, here we have to manage cavity access by an indirect restoration. So we have to take care about two aspects. The first is again to take care and preserve, to touch the pulp chamber floor, and the second aspect is to do the much more conservative cavity access in order to do a simple restoration at the end of my endodontic treatment. So what I did in this case is just to pre-configure the position of the orifice inside the occlusal surface of my composite only, and I know that I have to spare something like 2 millimeters on the mesial margin, and I have to search the distal root about 1 millimeter far from the red line that cut exactly in two halves the occlusal surface of the tooth, as you can see in the nice schema on your left corner. And another very nice aspect is also the inclination of the burns that has to be maintained. So just maintain not the two dark lines that I show you on the big screen on the coronal portion of the tooth that we are beginning to create an open cavity access, but the red line, because the red line is exactly parallel to the mesial margin of the tooth. So considering these two aspects, this is my final cavity access, and it's quite simple, quite little. I have a straight line access on all the orifice, and with this type of approach, once I finish my endodontic treatment, I really have no problem to do a simple endodontic, occlusal restoration. So I just find the working length in all the canals. So on the upper X-ray it's just the scouting, where on the mesial aspect I was just a little bit longer. So I take on the two X-ray on the below, I take one with the final mechanical instrument that I use it, and in this case it was I think a ProTaper Next, and then I also check that the mesiovestibular has a confluence in about 1 millimeter from the working length, and then I check also the right working length with the last instruments that I use it on the distal canal. And so this on the right side you have the final restoration and also the final alteration, where you cannot appreciate probably nothing in terms of recover, because I just did it a very easy simple obturation, preserving a lot of tissue. And also it was a really nice case, because using this type of approach I could have the help from the pulp chamber floor to find easily the canal. Let's move to another case, and again it was a really old case on a patient that I just remove old amalgam restoration, and in this case I think it was something like 7 years or 8 years probably. I removed the amalgam, and he became after 8 years painful on the second lower molar. And on the right side you can appreciate why, because with the build up I go again like the case done before, very close to the pulp chamber, especially on the distal aspect of the pulp chamber horn, and we already have also it seems an enlargement of the periapical portion on the mesial root. So I have to treat the tooth, and again the approach is to do a cavity access that should be much more conservative in order to do as final restoration a simple occlusal restoration. So first approach, a preliminary cavity access design. So just enter inside the canal with your diamond burns until you take care, you take contact with the pulp chamber. Then you will do with a multi-blade non-cutting tip burn the enlargement, and you can appreciate that we have some pulp tissue that it was quite inflamed, and then the refinement with the ultrasonic. So these are the 3 steps that I usually do in my clinical everyday endodontic treatment. And you can appreciate also, and again here, how much tissue we spare. So about 2.5 millimeters of mesial crystal margin, and we try to face the the distal orifice 1 millimeter half from the ideal line that cut our occlusal surface of our lower first molar at half. So just take care of the working length determination, and here we have again that the mesial root are confluent, and we have just a 2 distal root that again are confluent at the end of the orifice. This is the first image taken by the photograph taken by the microscope, with the camera with the microscope, and then a particular with a little bit magnification, and you can appreciate the 2 orifices on the mesial portion of the root and the 2 distal on the distal position. And you can also, I would like to underline what you can appreciate with high magnification, the sign on the pulp floor that leads you to the position again of the orifice. So that is very important not to touch it. So on the left side we have the final obturation done with continuous wave of condensation in all the canal, and on the right side also the coronal seal, that again is much easy because we have just to fill a very little cavity access done without touching the pulp floor, as you can appreciate from the 2 final X-ray. So this was about talking about the removal or the taking care, that's probably better, of the coronal restoration when they are done by a direct composite or indirect composite. So when we have to face with simple direct or indirect restoration. But what happens when we have to take care a treatment or a retreatment with a crown restoration? So basically we have 3 types of approach. We can remove the coronal seal. We can do it by the coronal seal, so it means by the crown, or we can sacrifice the coronal seal. That means we can cut the crown, and then we have to plan for sure another crown. And take care, and I will show you later, when we decided to to follow this approach, especially when we have to manage this type of situation, of clinical situation in aesthetic region. We cannot leave the patient without any crown after our endodontic treatment. So we have also to prepare a provisional that we can put on the tooth that we had the endodontic treatment, and for example also the endodontic restoration after endodontic treatment, to leave our office with a provisional restoration, a provisional crown. So basically, when we have to, let's move to the first step, and the first approach that I would like to share with you is when we decide to do an endodontic treatment or endodontic retreatment by a crown. So basically, what we have to manage, isolation of the multiple isolation of the tooth. In this case, so I don't put the clamp directly on the tooth where I have to remove, or to for in this case just to do the cavity access by the crown, because the clamp is on other tooth behind or two more behind. So use a diamond burr to do a cavity access that has to be just a little bit larger compared to the one that you would do if the tooth would be a natural tooth. So just, especially if we have a metal crown, just remove with a diamond bar the ceramic layer. After that, just take a multi-blade burn and do a cavity access inside the metal, but without touching, if you can, the margin region with ceramic, to avoid that with the vibration some layer of ceramic could cut out from the crown and you cannot use it anymore as final restoration. So here we have cavity access. So remove the ceramic and then remove also the metal. I was a lucky operator, a lucky clinician, but because in this case, as you can appreciate, I did not do as I recommend to you, because I just finished the cutting ceramic and cutting metal at the same level, but you have to maintain a little bit space between them in order not to again create some chipping of the ceramic layer with the vibration of the multi-blade burn when you remove the metal. So let's have a look of this video that is done by Dr. Cliff Raddle, where he face in this upper molar, and we can appreciate the step-by-step cavity access design. So as I told you before, just remove the the ceramic layer, then inside the metal layer, and then once you have bypassed the metal layer, you just arrive in the dental tissue and you try to find you manage your cavity access just a little bit larger compared with the ones that you usually do, because you don't know how is prepared the tooth under the crown. So as you can appreciate, as Cliff Raddle did it in this video, the cavity access is quite huge comparing the one that you usually do, for example, treating an upper molar, in order to have the access to all the orifice, because easily we don't really know the inclination of the preparation that is behind the crown. So in all this case, and we have here a patient that come, and you can appreciate on the left X-ray the lesion that is connected to this second lower premolar, and I did it a cavity access, just not removing all the bridge, but just also if it's a bridge, a nonsense bridge, okay, doesn't matter. But the patient want to maintain the original bridge, and so I did a cavity access by the crown. And what you can appreciate is a very nice third apical delta. And the same I did it in another patient with that strange. It's not come from the same dentist, but different dentists sometimes have strange ideas, like they want to do a distal cantilever. And again, also this patient don't want to remove the bridge. It was a referred patient, so I have to take care of him in this particular condition, where we have a lesion that is periodicular and enters also the distal portion of the root. And if you appreciate, also we have some nice anatomy that comes from the apical portion of the root, and every time during our obturation we arrive to this level of sealing of the apical portion. That means that our cleaning, shaping, and obturation, and especially the cleaning on the apical portion, was done in the right way. And we have for sure the obturation of all the exits of the apical portion of the root. So let's have a look some other cases where we have to face the anatomy or the endodontic anatomy of different tooth in different patient condition. This patient came in my office after he had an endodontic treatment, and after the endodontic treatment he feel again and again pain, and he has also a fistula on and an abscess also coming from this first upper molar, and the dentist thought to do, because he put on a crown on the tooth, to do an apical surgery. So he do an apical surgery, but the problem continues. So the patient come, you can appreciate on the left side X-ray, where we have a huge lesion on the mesiobuccal canal. We can also appreciate the retrofilling on the mesiobuccal root. And on the right side you have the occlusal view of the crown, and also the buccal view with the fistula. And you can also appreciate the scars of the old surgery that he did it. But I just take a CBCT in order to understand what it was wrong in this tooth. Well, it's really easy, and we can probably appreciate from this view, and I will just stop in order to let you understand what is wrong here. You can appreciate that the old dentist didn't find the mesiobuccal canal, and from this point of view we can also see that the mesiobuccal is completely mesiobuccal 2 independent, and we have a really huge lesion that was depending on the mesiobuccal. So again I arrange a cavity access that is quite a little bit larger than the one probably I will manage on a natural tooth, in order to again remove all the material, the filling material present in all the canal, cleaning and shape the main canal, and then try to take care of the accessory canal that I know that are present from the CBCT. So again, palatal, mesiobuccal, and distobuccal. And then what I found is, just for curiosity, because as you can appreciate from the picture, I didn't clean and didn't take care about the main canal, but I was so curious about the presence of the accessory canal, and that is. But I came back again just to fit behind, again take care of the main canal, shaping, cleaning, and then go ahead as I did it, because you can appreciate how much is clean the pulp chamber, how much are the orifice of all the canal clean, and then I can easily find also seeing the bubble coming out from the portion, from the dome where there is the accessory canal. And this is the fourth canal that is quite close to the mesiobuccal one. So take a look how should look the pulp chamber floor once you have cleaned it in the right way. So these are the intraoperatory X-ray, when you can really appreciate the working length, not only the working length, but how is the independent, the mesiobuccal 2. I remove also the material from all the other canal. I really didn't understand what type of surgery did the dentist, because, well, I didn't find any material, so just probably he just only cut the root. And I prefer in this case not to do another surgery, because I have to manage a very long independent canal that was the mesiobuccal 2, so it was not so easy to manage a cleaning and shaping by surgery level. And this is a 1 month recall, and you appreciate that you can appreciate that the tooth, it seems, that has a beginning of healing. And tomorrow I will have also the 1 year control. But the good news is that when the fistula disappears in 2-3 days, it doesn't appear anywhere and in any time, that means that your approach was right. And that happens. So I'm really curious what happens tomorrow when I will do at 1 year another X-ray and another CBCT to check how it goes. And let's see another nice case. This patient come with a very huge abscess on the lower first molar, where you can appreciate we have a strange endodontic treatment, because for sure we have not a correct management of the endodontic anatomy, comparing the profile of the mesial root to the material that is filled inside it. There is not any asymmetry. So probably or the dentist missed some canals, or there's something wrong here inside. So the question is, how can I manage this situation in order to solve the problem? Do I try to think about directly surgery, apical surgery on the mesial root, or do I think to something else? Well, the answer probably will clear after a CBCT, where you can easily see which is the problem. And I would like again, sorry, to underline that the problem is connected, and we can see here clearly. And then I also would like to stop the other video and to underline also the condition of the other video. The problem is connected on a presence of a canal that is the mesiobuccal, that the dentist didn't find it. So the dentist just obturate the lingual, the 2 distal, but not the mesiobuccal. And unfortunately, the mesiobuccal was independent. So in this case, should I treat it by surgery? Could I guarantee a nice cleaning and shaping of the entire canal just from the surgery aspect, I think that probably the best things is to do an orthograde retreatment by the crown, just taking care only of this canal at the dentist request to me. So these are the images that I take when I did it and I performed the cavity access. So it was just a design of the cavity access only in the mesial portion of the root, and it was not so easy, but using the microscope the life was just a little bit much more easy. So this is the canal that I found it under the microscope, with some necrotic tissue present inside. So clean, shape it until the working length, and I use it not to have some difficult on the resistation, the right working length, because of the metal present. I just use it at the beginning a K file, and at the end the final reciprocating file that I use it with Teflon inside, in order not to touch with the metal the metal portion of the crown. And this is the working length, and this is the obturation done with a continuous wave, and this is the final obturation and the check 3 months, and then 1 year when we have a complete resolution of the situation of the tooth. Just go ahead to another case. Patient come in my office, send it to my attention by a dentist, and again he said that he has problem. We have fistula that is present on the mesiobuccal root, and distobuccal root, an old crown. And again, the approach is, should I take care of this endodontic treatment by surgery approach? Should I take care of this endodontic treatment by removing entirely the crown, or just make a hole inside the crown by the crown? Where every approach has some advantages and disadvantages. Let's take care about the big disadvantages that we have in every approach. From the point of view of the surgery, in this case, we have to manage a portion of canal that aren't completely clean and shaped, and for sure we don't have a very nice endodontic treatment. So, in my opinion, is not the right choice. So the second approach is just to remove completely the crown and take care of the tooth as it is, removing also the post. And again, I think that is not the right choice, because the disadvantages are, and you can appreciate from an X-ray, that probably the tooth is really hard reconstructed with materials, and so has post with material. And once we remove the crown and all the material, probably we have the choice to remove also, to extract also the teeth, because we don't have any dental structure to put another new crown. And just talking with the patient, just showing the different options that we have, we decided to do the endodontic treatment by the crown. And just if we see inside the crown with the height magnification that the microscope gives to us some decay, probably we decided to remove also the crown and take care to all the tooth without crown. So we proceed with this type of approach: isolation, then remove the ceramic layer, remove the metal layer, and then this is how is the situation with the post that is a screwed post inside the distal, inside the palatal canal. So remove it. Working length determination, and here you can see that the two canals, so the two mesiobuccal and mesiobuccal 1 mesiobuccal 1 and mesiobuccal 2 are independent. And here the final X-ray, and then I send the patient back to the dentist who did it a restoration with the post, and this is the check, 3-month check, and this is the 6-month check. So there is a little bit lesion on the mesiobuccal, is not completely healed, but the healing is, I think, is processing nicely. We didn't have any formation of fistula, and the lesion on the distobuccal and the palatal is completely done. So we have the final healing on the other two roots. So on after 1 year, I will take care taking a CBCT as I did it at the beginning, and another X-ray to check really how is healed. And talking about doing cavity access by the crown, please be very careful, and please taking attention if you have to do a cavity access by crown or by bridge, especially because we try to imagine that our tooth that are under the bridge, like in this situation where I have to treat for pain reason the molar, we could have to prepare tooth under the bridge that has to be realigned. So don't do the cavity access as you usually do, but try to imagine where the prepared tooth is. So in this case you have to prepare the tooth much more distal, so much more far from the mesial margin, unless you take the risk to create a perforation on the mesial root. So I use this type of approach, and at the end this is my final endodontic retreatment approach. And take care of this case because it was very nice, because it is a real old case that I did it when I was just only endo consultant, and the owner of the office just prepared the teeth in order to put a final a definitive bridge without any provisional. And after the preparing, so the realigning of this first molar and with the first premolar, the patient after 1 month, probably connected also with the cementation of the bridge, has pain. So I had to treat it by the crown, and I think that is not very nice to make a hole inside a new bridge. But in this case I did it, and you can appreciate that we have very nice anatomy, so with two mesiobuccal canal completely independent. So the first part of our lecture was about the taking care of the crown by making a cavity access by the crown, and just have a very fast look how we can remove the coronal seal. So how can we remove the crown using different devices? So we will talk about vice devices, percussion devices, and active devices. So device devices is like this, that you can use in order to remove, I think, only provisional or only crown that are cemented with provisional sealer. So this one for the metal or resin crown, and the one with the silicone on the branch on the left side of the images for the ceramic crown. So this type of devices, you can use it only in cases you have cemented your crown with provisional cement. Otherwise, what I think all of you will used to do is just to use this nice dental little hammer, where, well, I think actually I use only to decement bridges that are cemented in a provisional way with really soft motion. Otherwise, if you have to the cement to remove old bridge, old crown cemented with definitive sealer, using this type of devices, you can create pain for the patient, create a luxation as you indicated from the animation on the right side of the video, and you can also have a risk of fracture on the build-up on the dental structure. So I would like to ask to you, how many of you use this type of devices, and during the removal of the crown come out, for example, with a portion of dental structure? And we can easily lose, for example, a ferrula effect because we lose dental structure. So we can also, to rearrange again our treatment plan, we can lower the prognosis of our tooth. So I will recommend this type of devices to use only again to remove crown on bridges that are cemented with provisional cement. Otherwise, you can use different devices that are present in the market, like the Corolinoflex on the left side, or from the Antogir, the Ceph Relax, okay, that are quite similar. You can put it on your handpiece, and just they have a controlled motion, and using different type of equipment, you can remove easily bridges or crown, as illustrated from the two videos that you can see. So these are options. Personally, in my office, I didn't use it, but I just let you know that that could be a possibility, in order not to give an uncontrolled forces by the hammer, do it by our hand. In this case, you just change, in order to remove bridge, to move crown, different different tips, put it on the handpiece, and the motion has a really controlled power. What I use when I need to remove a crown of a bridge that, for example, I sealed with in definitive way from days, years, and I don't want to cut and remove completely the crown, but use it again, I suggest you this active devices. It's called MetaLift. So you just do a little hole on the porcelain with a diamond burns. Then you move it with a penetrating the metal layer of the crown, if it's ceramic metal, with a multi-blade cutting tip burr, until you reach the dental layer. Then you take from the kit this burr that has to penetrate inside the hole that you did it before, and with this burn has to be mounted in the low speed handpiece, and just remove and do a hole of the same diameter of the burns. Then you can use it, this burn, this special burn that is provided inside the kit that undermine the metal inside the metal lift, and then finally you can take the metal lift that is really a thread with a non-cutting tip. So you put the non-cutting tip in contact with the dental layer and just rotate it in order that the coronal will be taken by the thread of your of your instruments, and like an elevator, so like a lift, it moves coronally. So just take a look of this video when the clinician remove the bridge, doing a hole in the molar and in the premolar. You can also appreciate a sequence of images inside the video in order to understand how it works. So first, with diamond board on the occlusal surface, do a little hole in the molar and also in the premolar. Then the second step is using a multi-blade burr in order to penetrate inside the metal. Then you use the burn that is inside the kit to underline your preparation. After you do the final cutting with the burn dedicated, so the burn that do the final hole diameter as the thread that you use to lift the crown from the tooth. So finally you will have a crown or a bridge with two hole on the occlusal surface that you can fill it with temporary material, unless you finish to treat your teeth in this case, or your tooth when you have to treat a crown, for example. So here is the underline burn to underline your hole did it from your specific tools. And now here just screw, and another one also in the premolar. So, and then we have it. So if we take a look, so some cases, here is a dentist that recommend me to remove the crown. Instead, I think that this crown doesn't deserve to be the definitive restoration, but again, I just take care about the restoration, where I have also to manage a perforation. And here is how I remove the crown. So just a little hole, or in a case where probably does make sense the removal of the crown, that it was very nice, but the endodontic treatment, as you can appreciate, was not so nice because of a very not so nice cleaning of the third apical portion of the mesial root, and so I have to remove the crown, did again the retreatment, and then the dentist take care about the repositioning of the crown. So in the commerce there are present other instrument that works in the same way of metal, like the one key, and again the principle are mostly the same. So do a hole inside a portion of the crown, and then in this case horizontally, until you reach the center of the root preparation, and then you insert the one key to rotation, handling, and to remove the crown. So let's take care of this animation. I didn't use in my everyday clinical this type of tools. When it happens to me, I use the MetaLift, but probably I will show you what is the most common approach that I will actually use. So again, insert the one key, and then a quarter of round. There are two different measure of one key. In this case, better to use the bigger one, unless pulling you can flip the crown out. And the third option is to sacrifice the coronal seal, so it means to remove completely the coronal seal, and so the crown. And I will tell you probably honestly that in 80% of the case I prefer this approach. For sure, for every of my patient I suggest this type of approach. When especially because mostly of the crown has problem in order to connecting to leakage, connecting to problems of seal or cervical seal. So I prefer to do it, and to do it you can use burrs for ceramic, resin or zirconia that are diamond burrs with different type of granulometric presence inside the burns, or metal. And we have two versions of the metal one. The one that is done with a hand gold handling. In this case, the cutting portion is gluing, is sealed on the handling, and this is the one that when you applied, for example, much more power will come out, but is the better one because the vibration that comes from the handling are transferred on the cutting portion and not to your handpiece, so will save the life care of your handpiece. So I prefer the one with the gold handling. So let's have a look to the anterior region, and this, when you have to manage the remotion of a crown on the anterior region, for sure you have to take care also to not leave the patient coming out from your office without any restoration. So you have to take care, if you don't have the Cyrex, so to do the possibility to have a provisional immediately in your chair, to take an impression before you achieve all the removal of the crown, all the treatment of the endodontic treatment, so in order to your technician to do a provisional. So removal, and this is a video where I improve the velocity of the video, the speed of the video. So this I have to remove the crown from the buccal view until the palatal view with a diamond burr. And when I reach the white layer, the layer of the sealer present, so I remove with an excavator the crown. Here we are. Then I take care to remove also with the ultrasonic tips the sealer, and then I create space around the post that is present here inside, and then with the ultrasonic tips I remove the post. try to do it with high magnification in order to preserve much more tissue that I can. And let's see, when you cut it at high magnification, we are at 20 magnification with the microscope, you really preserve a lot of material. And here is the removal of the post using ultrasonic tips, and you can see that the post is beginning to moving, so it come out, and then I have to take care what is present inside the canal, so the old sealer, and then working length. So I obturate the canal with continuous obturation. I treat in this way the tooth because the patient has something like 85 years old, so I don't want to try to think other type of treatment plan for the age of the patient. Then I put it provisional, obturated the tooth for sure, provisional until I reach the final healing, and then I will put a definitive crown on this patient. This is another case where a patient comes. You can appreciate on the apical portion of the figure on the left side of the slide, there was a fistula present. The patient has something like 42 years. So the X-ray show that we have a external resorption and also a post with a crown. So, well, it's a hard case to manage, but again, the options are to do a surgery with 2-3 millimeter of apex present, extract the tooth and do something else, or try to disassemble and to look what we can do. Well, the way that I decided it was to do a disassembling. So I removed the crown, and this is the length of the tooth. So disassembling, remove the tooth, and this is the post. And we will speak about the post removal on the next webinar. So the next Tuesday we will speak how to manage, how to remove without any fracture risk threaded post, anatomical post, fiber post, and in this case I had to manage also a tooth with an apex with resorptions with a big dimension, so I decided to obturate it with MTA and put MTA, so put MTA at the working length at the apical portion with this type of syringe that is MAP system. So you can see that when you push the apical portion, the plug come out and will push the material where you want, in this case at the apical portion. So take the material that has to be in this consistency. I put always, when I have to manage the apical portion of the canal, a barrier of collagen to have, and in this case, a very nice view of the depth of field where I have to put my material and plug it. I can plug with a Schiller plugger and also with paper point. Sometimes I use also, as you can probably see in another video, brushes. So this is MTA. Then I put a core restoration, then a provisional, and this is a 1 year check, I think. No, this is the final with the provisional. This is the 1 year control with a desilicate done by my technician Simone Maffei. We haven't any lesion yet after 1 year, and this is a check at 8 years control, where all is fine except for a chipping that the patient has on the incisal margin of the crown. And if we take care about the posterior region, when again I prefer to remove the crown, what I did it from the buccal view to the occlusal view is the same, so just cut the until I reach the from the ceramic to the metal layer, and then I can use a skewer to screw and flip the crown from the from the prepared teeth that is beyond the crown, or just to cut it completely. So in this case I cut completely the crown to do a retreatment, and again we have nice cleaning and shaping that are documented by our final x-ray, where we obturated also a very nice lateral canal, and then I send it back to the dentist that do the final restoration. This is a patient that came in my office because he changed the dentist, he changed place to live, and decided to be checked by my office. And this was a crown that was done 3 years before, and you can appreciate the lesion that comes on the distal root, and also the skewed post that is really hand skewed on the distal portion of the root. And we have for probably half root, mesial and distal, that are not clean and shaped correctly. So the approach is to remove the crown completely. So cut the crown, remove the old material that was part of the build-up, remove of the decay that was present on the distal portion, isolate with, again, once I did the treatment, and in this picture I already did it, with liquid rubber dam, and then I take care on the restoration. So just sandblast the preparation, and then I take care of the distal portion using a composite that is very flowable, is STR from the Sply, and then I put 2 posts and use a core build-up that is use also the material that I use to seal the 2 posts inside the canal, the distal canal, and this is the Corix flow. And then this is the final restoration. I prepare also the tooth and put a crown directly. And this is the check after 1 year with the final crown sealed on the prepared tooth, when we have a complete healing of the lesion. Again, the patient come in my office because he feel a not so comfortable sensation on this old bridge, and if we take care about the X-ray, you can appreciate that probably the problem are coming from the molar tooth, where we can probably have the sensation that we don't have anymore a nice feeling, a nice sealing. So I decided to cut remove by cutting the bridge. But if you want to do this approach, you really have to have prepared in the day you want to do the endodontic treatment, if you want to do it, a provisional bridge. So this is how I remove the bridge, and you can appreciate from the picture of the bridge removal that again we didn't have any seal more on the molar. So our diagnosis from the X-ray was right. I did it in this case a double endodontic treatment in order to, when I put a new bridge, to don't have to manage future endodontic treatment, because also I have probably to contouring the preparation, and I'm the limit of the 2-3 millimeter of healthy dentin around the pulp in order to maintain the tooth vital. So I decided to do endodontic treatment in both the teeth. Here is the molar that has a C-shaped canal with 2 orifices. And here is how I manage in the same step, in the same appointment, the premolar with the nice rubber dam isolation liquid obturation. And here we have the obturation of the molar and also the obturation of the premolar, and also the restoration with the post. So this is the provisional that I did it directly on the chair with the CEREC, and then in the same way I did it the final restoration with the final bridge, did it again with desilicate and done by myself on a chair side. Last 2 cases that I want to show you to end my presentation about the coronal restoration management is the case that was sent to me by a dentist. So I removed the crown. This case was done in the past by the dentist that didn't find the canal, and the patient actually with this provisional, it was a treatment that the dentist did it 2 years before, and you can appreciate the lesion. So when I achieved the cavity access, that's what I find it. So distal mesio-lingual, but in the mesiobuccal what I found is this. So blood coming out. So it was not the right position where I imagine to find the mesiobuccal, because the mesiobuccal was in much more in mesiobuccal position, and you can appreciate probably looking the mesiobuccal aspect a little right blood point, that is where the mesiobuccal is. So I scout it, perflare it, enlarge it, and you can appreciate that now we have the position of the mesiobuccal, and what the dentist found it was a perforation. So I found the work in the right watery length in the mesiolingual, mesiobuccal that are confluent, and the distal. And now you can appreciate better the mesiobuccal and the perforation. This is the mesiobuccal once I shape it. I have to take care about the perforation. So I put inside the canal a gutta percha point, and I take care about the perforation using MTA. And in this case you can see that I plug it with shield plugger, and then also with some nice micro brush in order to have much more control under microscope of the position of the material. Then I put a cotton pellet, wet it, sorry, and in the next appointment I check the hardness of the MTA, remove the gutta percha inside the orifice, and take care on the cleaning and final obturation of the canals. So this is once I take care of the second appointment, where I take care about the hardness of the MTA, and I seal with continuous wave of condensation all the canals, and I put the crown in the provisional way in order to let the dentist do whatever he wants. And I want to finish my presentation with these last cases. With last case, and it's a patient of 26 old, a female, that came in my office because the boyfriend is actually a patient of mine, and she go in different dental office because they all they suggest to her to extract the tooth and put an implants, and she don't want it. And which are the problem? The main problem, well, we can appreciate from the x-ray of the left side that there is a huge lesion that interests all the mesial root. Then we have a fistula, but I cannot really find a bone, vertical bone sounding, probably also because on the configuration of the crown, and we have also the chipping on the ceramic on the distal aspect of the distal lingual cusp. The thing is, could I have a fracture suspect? Well, the first idea was that, well, the tooth is fractured, so, well, we have to remove it. But I want to go further, to investigate much more, and I try to look at this case and try to see if during my CBCT examination, I could appreciate, for example, a perforation that originated by the post, and I didn't find it. So during my CBC evaluation, I didn't find any signs of vertical root fracture. So my decision was to go ahead and try to disassemble the root, try to find a vertical probing with my periodontal perio probe, and I didn't find nothing of this. So I go ahead and again with the microscope try to look inside the canal if I see some fracture from crack line, and I didn't find nothing. So go ahead and treat the tooth. That was what I decided, in agreement with the patient. So the obturation was done in the distal root with MTA because we have external resorption, and in continuous wave with in the mesial root. Then we put as final restoration post and core and the provisional, in waiting a 3-month, 6-month control to decide it if we can go ahead or extract the tooth. I asked the patient to call me after 3 days if the fistula disappeared, and that's what happened. But what's happened is that the patient, after 3 months, when she had to come and have to take an x-ray, takes a break because she was pregnant, and so I saw her after a year and a half, and the situation was this. So it seems that we are in healing. So I decided to go ahead and put a definitive restoration anyway. So I extracted the wisdom teeth, and in order to create space to put a crown, I put an ortho ring to create space between the provisional crown and the second lower molar. That is the result that I did it, and you can appreciate also the healing on the bone. So I put the crown, and this is a crown down by composite, and this is my technicians. So we started in 2 years and a half. This is the check on when I put the crown for the pregnancy reason, and this is the check 5 years control. And well, I don't know if the tooth could stay longer in the mouth, but now the patient has 31, 32 years, and the tooth is ready still in her mouth. So I hope you appreciate, you enjoy this webinar, and I hope to see all of you the next webinar, the next Tuesday, when we will talk about the removal of post from endodontium. If you have any question, just you can just write me on my email, and if I will just leave you a couple of minutes in order, if you have any question for me, to put it. Otherwise, you could easily have the time to write me an email and I will answer to you. So just 2 minutes, and then you can easily write me an email like some of you did it in the last webinar. Okay, so hope to see all of you next Tuesday. Have a nice evening, nice night, and let's keep in touch. So bye bye all of you from Italy.